In the first section on hyperfluorescence, we spoke about transmission defects. This is hyperfluorescence caused by an absence of pigment, generally in the pigment epithelium, whereby you see the normal choroidal fluorescence. In this section, we will start with hyperfluorescence because there is too much fluorescein where there should not be any, and in this section, we'll be talking about leakage from different tissues. First, let's lay out some groundwork by showing a chart comparing the fluorescent patterns and the differences between transmission defects and leakage. You can see on the transmission defect, again, there's not much early, and then it increases in the mid phase, and it then decreases in the late phase, and the borders are very sharp because they are bound by the boundaries of the loss of the pigment epithelium. Whereas with leakage, whether it ends up staining tissue or pooling in a space, you have a normal amount of fluorescein until the fluorescein actually leaks from someplace. In the mid phase, it is more than you would normally see. In the late phase, the dye continues to accumulate in whatever tissue or space that there is. So this is different from transmission defects, which in the late phase begins to fade. Now, depending on where the pooling is, the borders can be sharp or fuzzy, and what tissue that it stains can also be either sharp or fuzzy, whereas the borders in transmission defects are always sharp. So let's start by talking about hyperfluorescence secondary to leakage, and it will do two things. It will either pool in a space or it will stain in tissue. Now this will happen when there's a breakdown of the normal tight junctions or leakage from abnormal blood vessels which do not have any tight junctions in the first place. We'll talk about abnormal vessels in the next session. In this session, we'll concentrate on leakage caused by breakdown of the tight junctions that are normally there. Now these tight junctions can either be in the pigment epithelium or in the retinal vessels themselves. So first, let's talk about the fluorescein pooling in a space. If the tight junctions are retinal blood vessels that have broken down, the pooling may occur intraretinal, and the classic case of this is cystoid macular edema, whether it is post-cataract surgery, post-vein occlusion, or in diabetes. The pooling may also occur subretinal and either between the photoreceptors and the pigment epithelium, and that would be a sensory detachment, such as in central serous choroidopathy, or it may be under the pigment epithelium, such as in a retinal pigment epithelial detachment. So take a look at this photograph and look at it closely and see if we can come up with the correct diagnosis. Now, what you can see is an abnormal foveal reflex. It's not really sharp like it should be, and there are two small dot hemorrhages or aneurysms, one on the nasal side and one on the temporal side of the fovea. Now the nerve is pink and sharp, the veins are normal, there's no dilation, there are no cottonwool spots, no exudates. So this is not a vein occlusion, this is not diabetes, not hypertension, but there's a problem right next to the fovea. Now his history is, this is a 68-year-old who had cataract surgery 6 months before, but his eye was still red, irritated, and blurred. The vision was 20/60. Despite being on ketorolac and Pred Forte every day. Look at each phase of the angiogram. In the early phase, there's some normal splotchy, blotty hyperfluorescence and mottled fluorescence from the choroid, and this is normal. The foveal area looks pretty good. The midphase, however, you can now start to see some hyperfluorescence for 360 degrees around the fovea. And the late phase, this fluorescence is even more hyperfluorescent than the mid phase or the early phase. So it starts out with little, gets more, and in the late phase, even more so. Also note that the optic nerve is also hyperfluorescent. Look closely at the pattern of the hyperfluorescence, and this is what we call a petaloid formation, or a petaloid pattern. This is a typical presentation of an Irvine gas or CME after cataract surgery. You have the petaloid formation, and the nerve also is a bit hyperfluorescent. Here is the patient's OCT. The main things to notice are the intraretinal cystic areas in the foveal area. Now, he also has some subretinal fluid, which can be seen in severe macular edema, either whether caused by the Irvine gas syndrome or also with diabetic edema and vein occlusions. If you look closely, there's also a very small epiretinal membrane, but that is incidental and it is not contributing to this patient's edema. Pooling of the fluorescein dye can also occur in the subneurosensory layer or in the sub-RPE space. Serous detachments can be secondary to central serous choroidopathy or other inflammatory or exudative conditions, and this can be either from inflammation or from tumors. Pooling in the subretinal space comes from a subgroup of age-related macular degeneration called retinal pigment epithelial detachment. Examine this clinical photograph. First, there's some hyperpigmentation along a vessel superiorly, and this is a totally incidental finding. Look at the area inside the blue circle. You can see there's definitely an abnormal foveal reflex, and the look to the RPE is just not normal as you would see in other patients. And if you look three-dimensionally with this, you would see that the retinal vessels are elevated, but not the pigment epithelium. And if you can get your slit beam to the side, you'll notice that the vessels will cast a shadow on the pigment epithelium. And this is a case of central serous choroidopathy. And here's this patient's angiogram. You can see in the first angiogram, there's no hyperfluorescence. In the second and the third angiogram, you can see the fluorescein starting to build up. And actually, this is probably the dye leaking into a very small pigment epithelial detachment. And then finally, in the fourth photograph, this is a pretty classic smokestack sign where the dye is now leaking into the subneurosensory layer. Now you can see the fluorescein gets more and more and more as the angiogram progresses, and because the subneurosensory layer fluid is very diffuse, the dye borders are also very fuzzy. Here's another patient with central serous. He had a typical history of having a lot of stress recently. His father was recently hospitalized with a potential myocardial infarction, and just about 2 to 3 weeks previously, his younger sister underwent a 21-hour operation on her heart. So he had a lot of stress, and he came in with a several-day history of a sudden onset of a blur in the right eye. You can see in the right eye that there is some abnormal look to the foveal area extending from the nerve to just temporal to the fovea, and it goes from almost the superior arcade to the inferior macular vessel. The OCT demonstrates quite well the nature of the subneurosensory fluid. Now, in certain kinds of age-related macular degeneration, and occasionally in the younger patient, they may develop a pigment epithelial detachment whereby the retinal pigment epithelium becomes, quote, unglued, unquote, from Bruch's membrane. And if you do a fluorescein angiogram on these people, you'll note the fluorescein leaking into this space and pooling in this space. This is a 64-year-old gentleman who's had blurred vision in the red eye for about 6 months. His vision is recorded as peripheral only. The area encompassed by the blue line is elevated pigment epithelium. If you shine the slit lamp, you will notice that the blood vessels do not cast an abnormal shadow because they are still in the normal position overlying the pigment epithelium. A clue that this is macular degeneration and not central serous are the yellow hard exudates, which are not a part of central serous choroidopathy. This is a typical leakage pattern. On the early fluorescein angiogram, there's just a slight amount of hyperfluorescence temporal to the fovea where the pigment epithelial detachment resides. As the angiogram progresses, more and more dye accumulates in this space and the fluorescence becomes brighter and brighter. Unlike CME and central serous, these borders are fairly sharp because the borders of the retinal pigment epithelium are fairly sharp, and for this patient the dye is pretty much completely filling this sub-RPE space. Now, if the fluorescein or serum leaks out of the normal retinal blood vessels, it will either pool, as we mentioned, or it'll stain tissue. And in the retina, there's some non-cystoid macular edema or also perivascular staining where the dye stains the interstitial tissue. This is a case of diffuse diabetic macular edema. You can see from the clinical photograph there's severe hard exudates with a circinate pattern temporally. In the classic pattern of leakage, there's minimal hyperfluorescence in the early angiogram. But as the angiogram progresses, as more dye leaks out of the retinal capillaries, it will stain the interstitial tissue, and you can see that as the hyperfluorescence throughout the macula in this particular case. The borders are very indistinct because there are no anatomical borders that limits the spread of the fluorescein. Obviously, you can get this type of interstitial staining from either branch vein occlusions and also in juxtafoveal telangiectasia. This is a very specific style of interstitial tissue staining of fluorescein. This patient has a vein occlusion, and the tight junctions of the major veins are breaking down, and you can see leakage from the veins, and it is staining the tissue around the vein. You can see this type in any condition that will break down the tight junctions, which could include vasculitis as well as vein occlusions. So our first two examples of staining of tissue were just the interstitial tissue in the retina itself. But other tissue can pick up the dye as well. These will include drusen and fibrosis. And you can get fibrosis and collagen, obviously, in subretinal scarring, as well as the normal sclera and the lamina cribrosa. Some drusen can be either hydrophilic or hydrophobic. If the drusen are hydrophobic, they will block the dye. If they're hydrophilic, they will absorb the fluid and then they will stain with the fluorescein. Here is a good example of staining of drusen. You can see the medium and large size drusen in the temporal macula, and on the fluorescein angiogram, you can see that these are hyperfluorescent as the drusen pick up the dye and stain. Now, this is a particularly interesting case because There are 3 different reasons for hyperfluorescence in this patient. This is a 15-year-old girl who hit her left eye on the steering wheel during a motor vehicle accident. In the color photograph on the left, you can see the choroidal rupture, and you can see the white arrow that points to a pigmented subretinal neovascular membrane. In the early phase of the angiogram on the upper right photograph, you can see some hyperfluorescence fairly early on. This is a transmission defect coming from the choroid because the RPE has been broken in this area. The late phase photographs, you can see the hyperfluorescence because you can see staining of the sclera, and then you also have hyperfluorescence that the white arrow is pointing to, and that is from leakage from the neovascular membrane. And in our final example of staining, this patient unfortunately had an ophthalmic artery occlusion resulting in no light perception. On the clinical photograph, you can see an incredibly white nerve. All the vessels are white, and there are also some panretinal laser scars temporally. So there's some hyperfluorescence from the scars, but the main one to point out is this nerve also is very hyperfluorescent because the lamina cribrosa is picking up the fluorescein and staining with the fluorescein dye.